thank you for being perfectly on time and to save us for the next session. If there are any questions, I invite you to go to the J&J booth to do that to the J&J people. And thank you for everybody to attend this symposium.
We see each other at the dinner tonight. Yeah, perfect. See you.
Good afternoon, everyone. Do you hear me? Hi. Welcome to our session. Nice to have you here. The session is about patient engagement and current challenges in bariatric surgery and obesity. This session is very unique. We're actually going to go more broadly than just the surgical procedure, and we're going to talk about multidisciplinary team and clinical challenges, patient engagement, patient-centered care. I'm Tair Ben-Porat. I'm from Israel, and here are my esteemed colleagues. They can introduce themselves.
Thank you, Tair. from University of Portugal, Porto in Portugal. I'm Tharissa, endocrinologist from São Paulo, Brazil. Welcome, everybody. Okay.
So we're going to have esteemed speakers. Each talk is going to be about 10 minutes. And after that, I really invite you everyone to have a nice discussion. We're going to invite the first speaker.
It's Catalin Copaescu.
Yeah, that's me.
Thank you.
Okay. So thank you very much, and again, welcome to this event. This is the largest number in participating for IFSO EC Congress. So we are over 1,400 here in Malaga. I don't know if the city, the country is responsible for this, but we are so happy. And as you introduced, thank you very much. I think it's more than the surgical approach. That's much more than the surgical approach. So I'm going to try to give an overview of what we can think that there are challenges for the obesity and bariatric care from the surgical perspective, and not only. So nothing to disclose. So that's an overview of the presentation that I will pass through in my presentation. So there is no need to insist in these numbers because you know very well the impact of obesity. It's huge in numbers, and especially if you go for non-medical problems, which are all those many that are related there. They are related to the presenteeism and absenteeism related to it. So we don't value this when we have our meetings. But what I want you to look at seeing these numbers is the challenge of disproportions, because we are facing, as healthcare providers, physicians, anyone, a huge amount of work that we can get. We are a small community that, of course, for the future, we can think about changing these numbers, but that will be a work for generations. In the meantime, we see that even the actual job has a large disproportion, because we are speaking now in a sort of bubble. Those groups who act, who fight, really do something in this respect are pretty small. Let's recognize this. It is something we would like to be more, but in fact there are not that many. And there is limited impact on the voices of those groups that are here. So we hear each other, we align each other with what is in the next room. So we need to think about. So there are disparities in prevalence. Let me tell you, I will focus a little bit more to Europe. You know all these disparities. I will not insist. This is the global tendency. But if you look to Europe, there are between different regions of Europe an important difference. If you look to the south, you look to the east, there are 10% more patients living with obesity and suffering from, which means millions of people that are affected, and we need to think about what we can offer to them. And this is in the area when we can have efficient therapy, non-surgically, you know very well, and surgically. We have proven for decades that this is the effect. Now, despite we have these offers, there are disproportions in access to care. And I am sure that you will debate the ongoing discussion about the underutilization of any kind of therapy we can offer efficiently to our patients. Stigma, it is something you said, stigma police. Yes, we are many officers here, and we need to act in this respect. It will be a long, not painful, but a long process. And there are geographical and financially barriers for sure. and insurance disparities. So that's generally, there are many. I'm going to come more in details to a concrete study that we run in our country. That it's our Society for Metabolic Surgery in our country did a study in Romania got 20 million people and looked to those for 10 years old and above. And we found out that it's 23% of the population with BMI over 30, which is quite a number, and it's related to what I showed you, what is happening in the Eastern and Saudi Europe. But and then we translated this in absolute numbers to understand even more how many millions are suffering, and how many millions do suffer with complications associated with obesity. And we looked to something else that is related to disparities, to the income, that the household amount of money that those families do have is only in a little bit more than 10% of the patients above 2,000 euros. So that means that the rest, up to 90%, will not have any chance to get to any efficient therapy unless there will be a significant protection from any system to coverage. Now, there are disparities between Eastern and Western Europe, so we need to realize this. However, inside of each part there are differences, but this is overall what's happening in the West with a longer history of trying to control the consequences of obesity. There are programs, they are more and more aligned, which is not the case in Eastern Europe, and registries are almost not existing there. So we don't know that much in numbers. Despite this, there are efforts there to demonstrate that there is a significant financial benefit if we are using any kind of therapy. It seems that the decision makers there, the politicians, are still not hearing us. And I'm going to come to the point while I'm insisting this. And Eastern European countries, but not only, we can see here also in the UK, are vulnerable for the medical tourism. I'm not saying that this is something too bad to block anyhow the medical tourism, because it's going to fill the gap of the limited offers of therapies in the countries where these people are living. But we need to look at the cost efficiency versus compromising the quality of the programs. So no matter the therapy we are addressing, the model is challenging because the hospitals offer high efficiency efficient therapies on lower costs than there are in some other countries. So, but this with a compromise of limited investigations and preoperative workup, so that the evaluation is limited for some of the patients. And the high volumes, on the other hand, are improving the efficiency, so that at the end of the day, they will be cost efficiently. So they will always argue, we are much more efficient than any other hospital you value, and you say that you are the best. And this is also challenging for those hospitals who might learn from and improve, not only rising up the bar of the cost. Now, what is wrong is the poor communication there. That's for sure, because they don't know the language. We know that there are patients that even don't understand why and which kind of procedure has been offered to them. Just they know that it's a diabetes solution surgically to get rid of. And some years after, it's a disaster. But that's the situation. And they are blinded, them and their family, by some other less mercantile additional offers, like staying in five-star hotels, driving with a limousine, and so on. And sometimes they do receive too efficient metabolic procedures which got consequences, and they don't know, because I've told you they didn't understand what's happening inside of them. They are not able to translate. Also, there are complications. They are published so far. This is from the UK. And this is a concrete situation. That's a patient for diabetes, with diabetes, preoperatively, with A1C 6.5. So it was not a dramatic situation. But this is 2 years after. This is what is inside. You can imagine that the deficiencies are so high. So this is what inside of such a patient, that it's very difficult to reverse all these situations. And they simply don't know because of miscommunication. And this is why I think it's wrong with the medical tourism. Of course, we need to balance between democratize, we need more people to access any kind of therapy, and compromise. And it's the same for medication. I mean, if you buy it online, you don't know anything about it. It's happening the same. You got an easy access to any kind of medication, no evaluation before, and then what we can see, a lot of complications, they are not due to the medication, but due to the effect of medication that was not controlled. And we learn this as bariatric centers in time, and we need to share this. Now, I think that centers dedicated to obesity care, it's a challenging target, but we should think more about this. It was in the past, for many decades, a bariatric surgery center. We started from that idea to reduce the complications and to organize a multidisciplinary team. So we learned this in time, this is now the chance to center more the patients, not the surgical procedure, because those programs were designed to center the procedure. So at one stage, you will be evaluated for the surgery and followed up after the surgery, so that it is mandatory to have a surgery in those programs. But what about changing this? Because if we would like to work together, probably it should be placed in another way, fixing goals for efficiency and costs, not waiting too much time for one of the other type of therapy to reach success from this point of view. Do in the same way a preoperative evaluation, similarly with was in the bariatric program. I don't know exactly how to do it because the number of patients will increase. And then with the patient in center, deciding in a sort of metabolic board, what will be better for that patient? Will it be diet, will be medication, will be surgery maybe, or both? We will see, but it should be decided not up front like it's happening. I mean, I got a friend that is a physician. I feel that I need some GLP-1 agonist. I'm calling and giving me the medication, and then there are a lot of consequences that you are aware. Then again, we see that the bariatric surgery is going down now, at least for maybe it's correct to be like this. There is another offer now on the market. We don't know the adherence. In our country, the adherence for GLP-1 agonist is 4%, is 4 months. So that means that the numbers are growing, but that there are different patients that are recorded. We need to think about. And this got the consequences, because if we reduce the case volume, that means that there will be training programs for the surgeons. There will be some programs that will be closed. There will be challenges, cost challenges, and then we will have problems when we need really to do surgery. So that's, I think, again, this is in line with the idea of having a center that is dedicated to the patient rather than for a bariatric. And then finally is the patient, because patients need access to education, and this has proven that it is a case scenario with them not educated. And then we looked to our study again, and we've noticed that out of the patients with a BMI over 30, 22% didn't recognize that they have a problem. So no, we don't have any problems. We are healthy as we can. And of course, this is also with the education related. I will not insist because I hope it's not extended too much. And here the patients need to present their problem much louder in the community. The patients groups are for me a question. I don't know how it's in different countries, but I see patients that are the voice. I see people that are the voices of the patients, and they are not patients in different associations. So you know what I mean? I think this should be fixed somehow. And you have to believe that there are limitations in the way of being listened between the surgeons, the institutions, the hospitals, the payers, no matter interest they have hidden in their message, while the patients are not saying anything. They are not asking for anything. So they should be involved and put in front and voice their problem, and being together with IFSO, that's for sure. That's a project to involve more and more patients into the board and decide together with them if there is something to do. Then there are the payers. Look, they will be carefully looking even to the ORs. Expect to be the black box of the OR, so it will not be anymore a hidden place because it should be open anything. And probably from this point of view, the AI will help all of us in all the categories of our job. So I would like to conclude that there are important challenges to be faced by all of us in the multidisciplinary team, and the access disparities are to be addressed by all of us, understand and address. Maybe Center of Obesity Management, I don't know how we will call it, will be the future. The patients got an essential role, and this should be accepted, and we will continue this discussion for years from now because it's so long to do together. Thank you very much.
Thank you so much, Professor Catalan. Very interesting talk, a lot of challenges. Any questions from the audience? You have microphones here, you can pose.
Okay, so if not, we will discuss in the break. Enjoy the Congress. Thank you very much.
Now let's welcome Lisa Tovalnen. I hope I pronounced your name correctly. And she will be talking about patient engagement and long-term follow-up.
Thank you so much. I think you pronounced it. My name is Lisa Tolvanen, and I come from Stockholm, Sweden. And I'm going to continue talking about what you was talking about. So patient engagement and long-term follow-up. How can we manage to support our patients in long term so they stay with us? That's cool for this session. And I have nothing to disclose. And this is, of course, something that is clear for all of us, that obesity is a chronic disease and it has multifactorial causes. It's a result from complex biological, environmental, and behavioral interactions that affect metabolism, appetite regulation, and of course, health. So we need to have chronic disease management, long-term supportive care that focuses on health improvements, not just short-term weight loss. And what is in the center is this compassionate care approach. We need to reduce weight stigma and support personalized, ongoing management beyond weight loss. Metabolic bariatric surgery is, of course, the most effective treatment for obesity and related conditions. It has positive impact on health and quality of life, and it reduces morbidity and premature death. And this has been said several times during this Congress, but care continues after surgery, and it's not a standalone solution. We have to have this collaboration and partnership between the patient and healthcare team. Long-term support and follow-up, it requires ongoing care that supports long-term patient engagement by promoting sustainable health behaviors, monitoring nutritional needs, enabling early detection of medical or surgical complications. It also plays an important role in supporting mental health and overall well-being, while ensuring continuous obesity care and management. And this long-term follow-up allows for early identification of changing needs and enables care to be adaptive over time. It also provides essential support during life changes, stress, and different health transitions. But what does patient engagement mean? It means actively involving individuals in their own care and empowering them to take central role in their health. It is built on a strong partnership between the patient and the healthcare team, with shared decision-making and respect for the patient's lived experience. Access to knowledge, support, and ongoing follow-up is essential. When patients are engaged, it leads to better outcomes and higher satisfaction. Importantly, engagement is not one size fits all. It varies between individuals and across different life stages. However, there are barriers to engagement that can affect patient engagement at different levels. At the individual level, for practical challenges such as work, family responsibilities, limited resources, time, and distance can make it difficult to stay engaged. Previous healthcare experiences may also play a role, including fear of being judged, feeling of shame, or disappointment. In addition, priorities can shift as life circumstances change. At the system level, barriers include difficulty accessing care, inflexible services, lack of continuity, and limited knowledge about chronic obesity treatment and metabolic bariatric surgery. And of course, the patient-provider relationships is crucial. Communication quality and whether patients feel respected and truly heard can strongly influence their level of engagement. This qualitative study that we performed for a couple of years ago included 16 individuals who had experienced difficulties with weight management after metabolic surgery. And this graph here illustrates the two themes that we generated during the thematic analysis. It was clear that these participants experienced loss of control and focus with different challenges in everyday life, of course, changes in appetite, but also physical and mental health that contributed to emotional distress. But however, even though the other theme, reducing the burden of weight management, it illustrates that weight management is something that these participants experience very hard and difficult, and of course they would do everything to just like be, that they didn't have to think about this weight management. But they highlighted the importance of social support, support for self-care, while still acknowledging also benefits from the surgery. And I think these results highlight the patient's experiences several challenges, but may not have the support they need. And here is a quote from one of the participants. "I need to hear what I am doing right, but also how I can do more right." So we have to encourage our patients, support them positively, and not only focus on the negative side of what is happening in patients' lives. What defines effective follow-up? Effective follow-up is defined by a person-centered approach where care is tailored to individuals' needs and circumstances. It involves a multidisciplinary team working together with structured yet flexible follow-up over time, and collaboration between specialty care and primary care, supportive and respectful communication, and holistic approach that addresses all these factors. So we have to have strategies to strengthen the engagement, build partnerships with patients, use active listening, validate lived experience, encouragement instead of judgment, asking questions like, what matters to you? Flexible care delivery is also important, focusing on individual goal setting, peer support, ongoing support, and education. All these factors can strengthen the engagement. As take-home message, I would say that obesity treatment requires long-term, person-centered follow-up. And long-term outcomes is shared work between patients and multidisciplinary team. And patient engagement is built through respect, trust, and accessibility. So, thank you.
Thank you, Lisa. Anyone has a comment or a question for Lisa? There.
There is a microphone over there, if you may. Everyone can
Problem.
hear you.
Thank you so much. I loved it. One of the pointers in your presentation was that we really need to also include nutritional support for patients. As someone who is actively working on the medical part of nutrition, what can we do to increase nutritional awareness among doctors or patients? Any suggestions from your experience?
I think there is different ways to do that, but I think it's just like asking what you already know, that we don't give advices that people already know, because that's something that then the ears are closed. I think if we give advices that's not wanted or needed. So just asking questions, how is it for you, what you already know, do you want to know more? Also ask, is it okay if I say something about this? So giving advice with permission, I think, is one way. Of course, education, giving health-adjusted education, we have to consider health literacy, and that it's flexible, patient-centered, individualized, adjusted to patients' interest and need, that's maybe the most important thing as I see it. It's not maybe always more words we need. It's listening and hearing what patients already know.
Thank you. Makes sense. Yeah.
Thank you. Anyone else? No? Okay. Another one, please, to the microphone.
Hi, thank you again for a wonderful talk. I'm Zoe Bafili, a dietitian from Grace. So we're talking about long-term care for patients who have had bariatric surgery. What do you think is different between those patients and other patients that have chronic diseases like type 2 diabetes? They need to self-manage their disease as well, and they need to be followed up in long term. So can we base our work on that, on diseases already recognized and that have algorithms of care for the long term? Or what is the difference in patients with obesity? In persons with obesity.
I think it's good
Thank
to
you.
use the structures we already have for chronic disease management in most healthcare settings. So why not use those structures we have for diabetes or other chronic diseases we have? Oh, of course, I think it's individualized more than groups. So of course there is something we have to consider more with obesity and more with diabetes, more with hypertension. So every disease has its own questions. So of course there is something different, but I think the structure could be the same and build on that.
Please, if you have a question, go to the microphone, please.
Hi, hello. Thank you so much for the presentation. I am a clinical psychologist in a bariatric service, in 2 bariatric services in the UK. In one of the bariatric services, we asked the patients in terms of long-term follow-up care what they thought would be beneficial, and they mentioned psychological support. So from your experience and also from the feedback you got from patients, what do you think would be helpful? What did patients say that would be helpful in terms of psychological support? You mentioned emotional distress, loss of control that impacts outcomes long term.
Actually, that was the one main thing patients said. They wanted to have nutritional support and they wanted to have psychological support. This was the two most important what I could identify in these interviews. So more of that for patients. And it could be integrated. That would be the most. So we had dietitians who can do some psychological intervention and psychologists who can do nutritional interventions. Would be the perfect match, maybe.
Okay, anyone else? No?
Thank you, Lisa, for such an interesting talk. Lisa?
Lisa?
Dr. Lisa?
Another one, yes.
Sorry.
An interesting question. I took so much from your presentation. And I wonder if you could give us some tips on how to improve our communication with patients. You talked about listening, which really touched me, but maybe other tips for clinicians.
Yeah, that's a good question. How can we improve our communication? And I think motivational interviewing. Violetta is saying here, and I agree with her. Motivational interviewing, of course, is a very good tool for us to learn. And what is motivational interviewing? Of course, that's the next question. And it's a patient-centered communication style where we use, for instance, active listening to hear what really is important for patients and use different techniques to engage them. So motivational interviewing is good, but the other patient-centered communication styles are very, very important. And also this flexible. So we are like, we can use different tools like digital tools, meet our patients person to person, have video calls. So we are accessible for patients so they feel that they can contact us. And also this avoiding judgment and being kind, empathetic. Empathy is a good thing to show. And this, in motivational interviewing, you can actually measure your empathy. So that's also, you can go in training and record your conversation with patients, and your empathy can be measured.
Thank you so much for very practical tips. I think it's important for all of us.
Thank you.
Thank you, Lisa. Thank you very much. So I would like to invite a dear friend, Ximena. Ximena is from the Institute of Psychology in Sweden. Before Ximena starts, I want to invite you all for the Integrated Health Breakfast tomorrow at 7:45 in, what's the name of the place? Habega room, okay? It will be a second cup of coffee. Please come and stay with us, okay? Ximena, please.
Thank you so much for introducing me and for inviting me. It's a pleasure to be here. I am not a clinician. My background is public health, so that's my main disclosure. I'm not a clinician. I'm also going to go a little bit higher level in terms of connecting what we heard from the last two speakers about what I fundamentally believe is one of the root drivers of the inequities in stigma care that Katalin mentioned, and also the root drivers of lack of patient engagement in healthcare settings and patient engagement, which is weight bias and stigma. So I'm going to start, and I'm going to go very quickly with some definitions. Weight bias refers to our own negative attitudes and beliefs about weight and about people who have a higher weight. And these can be explicit, implicit, or internalized. Explicit means that we have very overt negative thoughts and beliefs about obesity, and we express those negative biased beliefs very openly and verbally towards patients living with obesity. Implicit is more unconscious negative beliefs about weight and about people with a higher weight. And internalized is when we take those negative attitudes and beliefs about weight and apply those to ourselves. And that impacts how we think about our own bodies and our own healthcare, for example. So weight bias can lead to stigma, which is a social stereotype that exists about people who have a higher weight or who live with obesity. And these are deeply socially ingrained stereotypes that people with overweight and obesity are lazy, unintelligent, unmotivated, or lacking willpower to change their behavior and to control their weight. This can lead to discrimination, which is the unfair and unjust treatment of people because of their weight. And unfortunately, there are not many laws against discrimination against people who have a higher weight in most countries, and that includes Europe. So weight stigma, once you become aware of what that is, you can see it everywhere. It's in media, it's in kids' narratives and stories and entertainment. It's pretty much everywhere, and you can't really avoid it. So once you become aware of weight bias, you see it everywhere. And that's the first warning to all of you, that if once you get out of here today, you might start seeing it everywhere. And the evidence shows that because it's everywhere, kids as young as 3 years old have weight bias beliefs and attitudes towards people who have a higher weight. And the prevalence of weight bias and stigma is measured, at different life stages. And so in this slide, you see that children experience weight bias and stigma, adolescents, adults who are undergoing obesity treatment. Even 66% of adults who are undergoing obesity treatment experience weight bias and stigma from their healthcare providers. And about 20 to 50% of the general population, so this is not just people with obesity, the general population, 20 to 50% are not happy with their weight and want to lose weight or want to change their weight in some way, up or down. So when we talk about weight bias and stigma, we need to think about what this means and how it's enacted. So perceived stigma is when patients living with obesity experience these negative comments and judgments, and it can come from everywhere, from their families, their peers, their healthcare professionals, their employers. And then experienced stigma is when those biased attitudes actually turn into behaviors against them or discriminatory practices against them. For example, when they're denied, like Katalin was talking about, they're denied obesity treatment. Or internalized stigma is more that self-devaluation, that feeling of shame that patients feel about having obesity because they have heard throughout those images that I showed you before that having a higher weight is bad. It's a moral character flaw, and if you have a higher weight, it's your fault, and you should be able to control yourself. Anticipated stigma is that fear of being judged for their weight that patients experience every time they go somewhere, whether it's a family event, a social event, or whether it is going to an obesity management program, where they're expecting to be judged and shamed for their weight. And institutional stigma, here we're talking about those policies and practices and social norms that we have in our society that discriminate against people who have a higher BMI, for example. And I'm going to talk a little bit about this. So from our research, I didn't want to go through in detail, but this is just one slide that summarizes the current evidence that we have about the impact of weight stigma on physical health, psychological health, healthcare delivery, and social outcomes. And I guess I highlighted in bold the impact on patient engagement in primary healthcare services. There's extensive evidence that weight bias and stigma breaks down the trust between healthcare providers and patients, and that affects patient engagement. So if a patient anticipates that the person that's going to talk to them about their health has weight bias and weight bias attitudes and beliefs, they're going to anticipate that they're going to be judged for their weight, and that's going to reduce the trust that patients have in their healthcare professionals, and it's going to affect the communication with you as a healthcare provider, right? They might not be telling you everything that is happening around their lives that may be impacting their healthcare plan or their healthcare outcomes. So in public health, which is my field of work, we consider weight bias and stigma, like all other types of stigma, like HIV/AIDS, mental health, diabetes stigma. There's all kinds of health-related stigmas, and we consider stigma a social determinant of health because it's an independent driver of negative and poor health outcomes, but it also causes a lot of health and social disparities. And those are the disparities that Catalin talked in his first presentation in terms of not only access to care, but there's also disparities in terms of people accessing general health care, not just obesity care. So how does weight bias enact in the healthcare system? It starts with these biased attitudes, the belief that weight is controllable through individual behavior and that's an individual responsibility. That leads healthcare professionals to not seek obesity training, and patients internalize the belief that they should be able to control and it is their fault that they have obesity. Because patients internalize that biased belief, they don't ask for help from qualified healthcare providers and instead go to those medical tourist places or evidence-based treatments for their obesity. Stigma happens when in the healthcare system, patients don't get referred for obesity treatment and are just told to eat less and move more. And discrimination happens when obesity is not treated as a chronic disease in the healthcare system. So no coverage for obesity treatments and denial of healthcare such as fertility treatments or knee and hip replacements, for example. So what we see is when patients experience this bias, stigma, and discrimination, it affects their health outcomes, it increases and facilitates obesity progression and reduces their quality of life. And so these biased beliefs, as Catalin was mentioning, leads to this therapeutic inertia, right? So this is a study with primary healthcare providers in Canada where they really believe that bariatric surgery is not effective and that patients they know what to do, they just need to do it more. So we know from current studies that only a small fraction of people living with obesity have access to treatment and structured long-term management, such as Lisa, what she presented today. That is a very small number of people that have access to that type of care. And there's many issues: cost, workforce shortages, lack of training, lack of reimbursement. But we see that one of the main aspects of this obesity care inequity is the idea that we frame obesity treatment as a short-term weight loss rather than a chronic disease treatment. So we need to change this narrative. We need to stop framing obesity as a weight loss problem and as a behavior problem. We need to combat those diet culture messages that I showed you in those images that spread misinformation about weight and health and obesity. We need to change those public health messages about eat less, move more, this is your responsibility. And we need to treat stigma as an independent determinant of health. And we need to stop talking about obesity as a personal failure and consider that there are many biological and genetic causes that cause obesity. And we need to use the new definition of obesity, which you may have heard throughout this conference, that obesity is a chronic disease characterized by dysfunctional or excessive adiposity that impairs health. So obesity is not just about weight, obesity is not just about body size or BMI, and BMI is just a screening tool. And we need to stop, and you heard this from the previous speaker, Lisa, that shaming aspect, that many healthcare professionals believe that if we shame patients, they're going to change their behavior and lose weight. The science shows that when patients experience shame, the opposite is true. People will avoid health-promoting behaviors, and it will cause a biochemical and cognitive and behavioral response in their bodies that actually increases weight and causes more obesity risk. There are many, many organizations trying to fight against weight bias and stigma, including IFSO. IFSO Global has a partnership with Bias 180, and Violeta Moise and Dr. Ricardo Cohen have led this initiative within IFSO, where we're trying to see what the level of weight bias is within the IFSO community and trying to raise awareness and educate and provide skills for them to address weight bias and stigma in their practice. So, many educations exist. I'm almost done. I see the clock ticking red. So weight bias interventions that we have to date in terms of the evidence, there are educating healthcare professionals about the biology of obesity can reduce bias and implicit bias. Attribution, removing that idea that obesity is an individual control can also reduce weight bias. Having more empathy, like Lisa was talking about, that those empathy-evoking interventions have been able to prove some success, and also to create more weight-inclusive societies where we treat everybody with respect regardless of their weight or body size. And of course, some policy approaches to prevent discrimination against people and treating discrimination as a human right. So, promising strategies include improving attitudes about obesity, training healthcare professionals, but the main responsibility in the healthcare system is in healthcare professionals and the system. It's not up to patients to be able to cope better with the bias and shame that they experience. It's up to us to change it. But we do need to empower patients to reduce their internalized weight bias and stigma. We need to use person-first language to reframe obesity as a chronic disease. Stop using words like patient failure, non-compliant, patient failed the treatment, for example. All of that will help us remove the shame and the blame around this chronic disease. And you can access this information through the EASO website. And so the call to action in terms of obesity is that public and private insurance should support evidence-based interventions and look at outcomes beyond BMI and weight loss, treat obesity like any chronic disease, like somebody else mentioned earlier, train healthcare professionals on the science of obesity and the science of obesity stigma, and empower patients to stand up and advocate for their health and well-being. So in the end, we can all make small changes, but we also need systemic changes and social changes. And the foundation to all of that is to communicate about obesity in a scientific base and a respectful way. And in the end, it's all about improving health equity for our patients. And I'm going to leave you for this 1-minute video. Sorry, I went over time. think there's questions. There's not enough time for questions.
We have time if anyone
okay.
wants to ask.
Any questions? Don't feel shy. I think all the questions that Lisa had were great.
But I do have one. Small
Okay.
one. I think it was this one. Yeah. Go ahead.
You can go first.
Yeah.
Yeah.
The mic.
Well, I think we made a long way, and I wonder, what do you think? Where are the improvements that the system made in looking on stigma? Where should we go from here? Like, what are the main challenges that we achieved, and what are the main
I
things
think
that we still do?
that's a really good question. I think there's much more awareness that weight bias and stigma are harmful, right? That this is not about being nice to people. It's actually harmful for physical health, mental health, and healthcare delivery. So I think there's much more awareness of that, and I think people are trying to address it. There's very little in terms of interventions at the social level, at the policy level. We still see those social norms, that the diet culture messages, that it's all about being thin. So socially, I think we need a lot more interventions there. In the healthcare system, I think there's a lot of progress in terms of reframing obesity as a chronic disease and moving beyond weight loss and BMI in obesity treatments. But despite all of the science that we have about effective obesity treatments, we still don't have access to those treatments for patients living with obesity, and it is because of the stigma and the belief that people have their own responsibility to control their weight.
May I? Yeah. Thank you, Ximena. It's a reflection. We were talking about this lately. Even it's between us that, you know, we feel we have done some things, but it's what you say, it's awareness.
Yes.
We are talking more, but not sure if really things are changing. So even between us, we are planning sessions in Congress.
Yeah.
And sometimes when I say, let's do stigma, within the committee still, some of the members say, no, it's boring, too much. Let's do something different. Why? This is not ended.
Yeah.
So we need to keep talking. Perhaps doing something different,
Yes. Yes.
but planning on this.
I agree with
Go
you,
there.
Violeta.
Done.
I agree with you, Violeta.
Just started.
Yeah,
The
I think a
beginning.
lot of people say, okay, they heard this presentation. You probably have heard this presentation before about weight bias and stigma, so you're aware that weight bias and stigma is an issue and should not be happening, and that patients deserve better. But healthcare professionals, I think, need more skills and better tools to actually implement and take action to reduce bias and stigma in their clinic, and also to advocate to their health system to make sure that we reduce stigma in the system. So I think that's the next step, and I agree with you. So motivational interviewing is one way that, that healthcare professionals can use to reduce weight bias and stigma. Because if you focus on the patient, and if you focus on what a patient needs, then you don't just entirely center on what we as experts think that the patients want.
Okay, a quick question.
Thank you for such an inspiring presentation,
Oh, thank
because I wanted to say thank you. I just realized I've been working as a dietitian for about 30 years with patients living with obesity, but I just realized that it is a stigma when in my hospital, I work in a large hospital in Greece, when the doctors refer patients with a BMI of 40 to the clinical nutrition department, so we give them a diet plan, and that's it. And when we say, no, we're not enough, that's what I want you to do for this patient. So this is stigma, and this comes on top of the other comment that's why it's so important that we address it, because it has an effect on the treatment of the patient who has the disease. So it's really inspiring, and it's really, it's new. So
Now you're not going to
so
stop
much.
seeing it. You're going to see it everywhere.
I see it. Yeah, I know.
Thank you for your comment. It's important. It's important. Yeah, thank you. Thank you, Ximena. Brilliant. Thank you.
So I invite Marie O'Kane to talk about integrated models of care and multidisciplinary teamwork, please.
Okay, where is the presentation? Oh, it's coming. Tem algum problema? There's a problem there?
I uploaded it yesterday, so
In the meantime, if anyone has another question for Jimena on stigma.
I've got it on the stigma. Did you do it yesterday?
Okay, let me check first. Slides.
Yeah, we are on time.
I did do it yesterday.
Cannot lose.
Okay.
Perhaps we'll skip this one.
Okay.
This is 10. Yeah, yeah, instead of leaving it. We have another one, no?
So, for the sake of discussion, obesity stigma, right? So it is a very important topic, but I do think we need some other approaches, because I think as professionals, we hear this over and over and over. But yet, I think Jamina, I think that's how you say her name, I think she had a very good point about the implementation. You know, how many times do we hear about, well, what can we do about it? How do we take that back to our practices, to our programs, to our chapters, to our countries to implement it? Yeah, so I would love to have strategies and there would be a great roundtable. So I'm going to leave you.
Thank you.
And Julie's my witness to me uploading my presentation yesterday as well. So thank you. Real pleasure to be here and great honour to be asked to speak. And I have no disclosures. So hopefully this will complement other presentations. But for me, what's really important is that person-centred care. That patient is an expert about themselves. We might be experts in nutrition or psychology, but we've actually got to build up that collaborative relationship and work in partnership with the person. So helping to actually understand their goals and what is driving them, and actually making sure those goals are actually realistic and achievable. But as a dietitian, I feel it's about helping people to make decisions and making sure that they've got access to objective information that's correct, rather than what's on TikTok and social media as well. So helping them to make informed decisions about their treatment. Now, the National Institute of Clinical Excellence has its excellent infographic, which is downloadable. And it actually talks about principles of care, about showing that respect for the person, supporting them, using the right language, really taking into account the culture, their beliefs, their knowledge, knowing about them. And for me as a dietitian, that is the nicest part about my job, is actually getting to work with people before surgery, after surgery, and supporting them, getting to know when the kids are doing their school exams, wedding anniversaries, who's going through a messy divorce, whose father has died, who's a carer, getting to know all that about them. And then helping, as already been talked about, you know, using that correct language and making sure we aim at the right level for that person and using the information and presenting it in a way that's understandable. And then really seeing it from that patient's point of view as well and really listening to them. Now, when people are coming to us for help with obesity, many of them have many other health-related conditions, and I'm seeing lots of different healthcare professionals who are probably putting pressure on them to lose weight and seek treatment. And then when they come to see an obesity centre or a bariatric surgery centre, they're going to meet endocrinologists, dietitians, surgeons, nurses, psychologists, psychiatrists, physiotherapists. And it's our responsibility as healthcare professionals to maintain that really good communication with the patient, but with other healthcare professionals that they are seeing as well. And making sure that we collaborate and actually giving consistent messages and actually sometimes supporting the patient to speak up to their healthcare professional as well. Now, traditionally, most people, if they're going forward either for help with treatment, it would depend on what the general practitioner knows. It will also depend on what's available in their area. And in Leeds, we were lucky that we did have a medical obesity clinic and also bariatric surgery clinics as well. What we found was that patients would be referred directly either for surgery or for the medical obesity clinic. And because I've been around a long time, I would know that that patient had been down that route for the medical clinic several times, and maybe the right time now was for surgery. Equally, we'd have people referred for surgery who didn't know what it was, they were scared stiff, didn't want to go down that route yet. And what we found that because we weren't able to cross-refer, people might be stuck in a pathway or would have to discharge back and then they get referred in again. And there's no way of crossing the system. Now in Leeds, we actually did something about that. And this paper, though it's released in 2025, we actually did this sort of model back in 2006. And we had a common entry point. And I was picked as the person who would triage and actually see patients for their first appointment. People might think, why dietitian? But back in the early 2000s, I'd had 20 years of experience already working with people with obesity and also in bariatric surgery. But from there, I'd get to know the person. I'd maybe seen them already in the obesity clinic. We'd actually present the patient's case to our multidisciplinary team. And then from there, we decide what maybe was an appropriate treatment. So then the next step would be to see either an endocrinologist, an obesity physician, or a bariatric surgeon. But if we hadn't got it right, there's an opportunity for people to cross pathways. But all the time, we've got to remember the patient's choice. Just because we think that's the most appropriate treatment, the patient might decide that that's not the right thing for them at that time. That was great. It's great when we started working with this model. It allowed people to pass between, but also allowed us to learn a lot from each of those professions as well. Sadly, in 2015, NHS England decided they didn't like the model we were using in Leeds. Everyone had to go down the medical route first before going for surgery. So a bit of stigma and bias, and we had to go back to our old model of care. Now, when we're actually thinking about multidisciplinary care, there's lots of benefits. We all know that. But for me, when we're actually looking at this, we've got to think about the relaxation, the hierarchy. Just because we've got, and I'm saying this as a dietitian, just because there's a surgeon or an endocrinologist or an obesity physician in the team, doesn't mean that they take charge. In the MDT in Leeds, I continue, despite us changing back to the old model, I continue to lead that MDT discussion. It's really important to have that relaxation hierarchy and recognise that everybody's got a voice. So it's not the surgeon's voice and the endocrinologist's voice that's the most strong. It's actually everyone has a right to actually give an opinion. We've got to really help with the patient and actually really make it known as to what the patient's motivations are and what they want to do. As healthcare professionals, we've got to have that mutual trust and respect for each other. We're going across professional boundaries, but as a dietitian, I need to know when I need to make sure that that person, it's the right time for them to be seeing the psychologist. You know, when do we need to fast track back to a surgeon? When do they need to see the endocrinologist again? And actually making sure that we keep that patient fully informed and actually think about that active patient involvement. So just to illustrate that a little bit more, I'm just going to talk through 3 cases based on patients, but obviously a lot of facts changed. Now this patient, this would be back probably about 2016 when we had to go back to our traditional model of people being in the medical obesity clinic first. This lady had 2 young children. I later found out that a 7-year-old had learning disabilities and that caused problems around meal times. She was a care assistant but was injured, couldn't work. In addition, she ended up looking after her mother who didn't live with her but had dementia. And she tried various diets, but more recently could only lose about 6 kilograms. Decided that she wanted to have metabolic bariatric surgery. probably the right decision. But meanwhile, she then got admitted to hospital with an infection. I can't remember what it was, but she was ill. She lost her appetite. She ended up on nutritional supplements because her appetite was so poor. Came out, was scared stiff of having surgery because as a single mother, looking after her own mother, 2 young children, if something went wrong with surgery or she didn't recover well, she was scared stiff. So she decided to stay in our medical clinic. We didn't have access to medications at that time as we do now, and she did really well. Now I'm sure that years later she'll be back to see us again, maybe thinking another option, and obviously medications are available. Joe, he had an old operation, Megan-Strassen Mill, back in the 1990s, did really well. I remembered him. He then came back, had weight gain, as would be expected, especially with this older procedure. Family circumstances changed, lives alone, vegetarian, low income, not great cooking facilities, osteoarthritis. And I know that one of the surgeons at that time were doing lots of duodenal switches, thought that was best operation. As a dietitian, vegetarian diet, low income, no cooking skills, no. So you can imagine that we had a really interesting discussion about what was the best treatment options available to this patient. Third patient, and this patient, more recent, buying obesity medications privately. In the UK, access is really dreadful to medications, really hard to get people access, and they can only be on them for a certain amount of time. Again, stigma, bias, everything else. So she did well with medications, lost 20 kilograms, couldn't afford to keep on buying them, had a very erratic eating pattern, misses meals, didn't eat, thought it was great, she didn't feel hungry, therefore would not eat at all. And when she did eat, it might be a boiled egg or the occasional yogurt. Diet was dreadful from a nutritional point of view. But prior to obesity medication, she used to binge eat. Now keen on having metabolic bariatric surgery. So if you think about it, the whole team needs to be involved, along with the patient, about what's the next steps for her. What help does she need if it's metabolic bariatric surgery? Does she need to see a psychologist? Does she need more support to actually normalise eating? What's going to happen when she stops her medication before surgery? So lots of things that we possibly don't know yet, but again, a team approach is really important. So just finally, just talking about the team-based care, yes, we need a whole range of professions, and I apologise if I've missed any of those professions out of the team originally. Access to training, education, and in Leeds, in UK, dietitians are trained in motivational interviewing and have been for the last 20 more years, but other team members need to as well. Making sure we've got a communication, really, really listening to our patients. Their decision is important. We might have an idea of what's the best treatment options, but it has to be the best thing for them at that time. So no matter what we do, we need to keep that patient focus. And for me, as a dietitian, that's always been the best bit of my job, is actually working with the patients. So thank you.
Questions from the audience? Anyone?
I just wanted to say thank you, Mary. That was excellent. And I loved the part about a relaxed hierarchy. That is such a cool term. I'm going to go back and use it. Okay, we all need a relaxed hierarchy here. Thanks.
Yes, thank you, Mary, for that presentation. That's great. And I think maybe Vicky will be better to answer this question also later. But I think my question to you is, is this idea that listening to the patient and doing what the patient wants and needs, how is this a novel thing? I know many people in my family that have had other chronic diseases, and it's always, their choice to have cancer treatment or not have cancer treatment, for example. But in obesity, somehow we get to this point where we question when a patient doesn't want to have obesity treatment. Do you experience this is an issue?
I think a lot of it is sometimes with the person themselves, it's actually lack of knowledge. or where they've got their information from, and actually sometimes being able to talk to patient support groups, good ones, moderated ones, and actually making sure they have access to that information. So I think as well, what we found is when we, especially doing the shared care model, is that patients get to know you as healthcare professionals. It takes a while to build up that trust as well. And I think also just remembering sometimes personal circumstances, they sometimes decide it isn't for me at this moment. But that one of the physicians I work for used to just say, doesn't mean that isn't an option. It's just not the right thing at this time for me. Yeah.
Yeah. So as healthcare professionals, our job is to respect that, to
Yes.
listen that. Yeah.
Yeah.
Okay, thank you. If there's another question, we can still. Okay, so let's welcome now Vicky Monet, and she will talk about voices of lived experience in bariatric and obesity care. Thank you, Mary.
Good afternoon. I was about to say good morning, but it is actually afternoon now at this stage. So good afternoon, everybody. So my name is Vicky Mooney. I'm a patient advocate. I'm a person who lives with obesity. I'm not a doctor. I'm not a healthcare provider. You will have to excuse me. I'm sucking on a glucose sweet because my sugars were low. But essentially, I'm the executive director of the European Coalition for People Living with Obesity. Now, we talk about challenges, and one of the challenges we have is that when a patient goes to speak, many people leave the room. And so therefore, I'm very grateful that you stayed when you heard patient and you didn't up and leave and go, I can go off and get a coffee and have a chat. And that's shown tokenism that we have experienced over the years. It isn't as prominent, and I'll be very straight, it isn't as prominent in the community of, I suppose, where we were founded from, EASO, European Coalition for, or the European Study for Obesity. We actually began there in 2013, did not realize why 13 patients marched into a congress in Sofia in Bulgaria, requested by EASO, and was in an environment where there was 2,000 professionals who were all talking about obesity. Now, I've never in my life felt more like a guinea pig in a cage than I did in that moment of the realization that they're all talking about people like me. They're all trying to, not physically, but psychologically understand, to delve in and understand the patient experience. I've had obesity since I was a child. I have, from my very first memories, being poked and prodded at, of the girl who always carried weight in her stomach, the girl who never had a boyfriend. I was all of the guys' best friend to set them with my girlfriends, but I never had a boyfriend. I was the girl who was 17 and met my husband, and I could not believe that he fell in love with me. He seen beyond the 110 kilos that was stood in front of him. So the challenges that we face as patients is that essentially we bring our lived experience. A lot of that is weight bias and stigma and the challenges we face and we go through. And it's still not listened to in the communities, and particularly in the surgical community. So I've actually got a question for you guys who are here, because we've lost a couple of people down the back who have tiptoed their way out. Don't worry, I eyeballed them, so it's fine. But essentially, Do we have surgeons in this room? 2. 2 more? Okay, so we have a handful of surgeons. This is get to know your audience. Thank you. Psychologists. Okay, normally we have a lot more psychologists in the room, so this is great. Endocrinologists. Okay. Clearly we don't have any GPs because they're terrified of the surgical community, so there is no GP sat in this room or nurses, am I correct? Yes. So we have a bit of a mix of a multidisciplinary team in the room here. And are we mostly dietitians? Oh, winner for the dietitians. I have sweets in my bag. They're glucose sweets, but I'll give you one on the way out for actually being here because you guys always support. So now that I know the audience a little bit more, what I can tell you is that part of the challenge we face is that many of you are not aligned with our surgical or our weight bias understanding, our stigma that we go through, why the patient voice is needed, why the patient should be an equal partner at the table. And when I say an equal partner, not a token, not somebody who rocks up because, oh, EU research, Stay Healthy Horizon has said, oh, you need to have X amount of patients on this project. No, it's because you want to understand at the end of your project, you want to get there and say, actually, the patient involvement had impact. And now, 5 years later, 5 years down the road, after a long slog of very scrappy money where everybody is fighting for it in a consortium, we've got to the end and we actually have a project that will impact the people on the ground. And those people on the ground are people like myself. But they're also people that you know and that you love. So here's the hard question. How many people actually in this room have people in their lives or themselves that live with overweight or obesity? Now, for those who didn't raise their hand, please stand. Who did not raise their hand. So if you do not know anyone in your life who has overweight or obesity that you love, please stand up. Okay, so essentially in this room, you all know somebody. You all love somebody. Now, if that person that you love and you adore and you care for wants to go to their GP and get a cancer diagnosis, what would you expect? You would expect shared relationship, understanding that this is going to be a treatment plan you come together on. You would expect empathy. You would expect support. You would have a multidisciplinary team rocking up behind all of that to make sure that you are getting everything you need. Instead, like myself, you rock into the doctor's surgery. You don't get an obesity diagnosis, first of all. You're taught, here's another challenge, weight loss. You just need to lose more weight. You haven't tried hard enough. It's your fault. You're gluttonous, you're lazy. You might not fit into your clothes because unless you actually realize the market of plus-size clothing is so much more expensive than it is for the average person, unfortunately. Many people who have obesity tend to also sit within that lower socio-demographic area where there isn't a lot of money. And you hear the stories, and you know what's going to happen when you rock up to your doctor. So would that be acceptable for you, for your loved one? Would you be okay with that person going in and being blamed and shamed for something that is neurological, psychological, that is a complex, chronic, recurring, progressive disease? I can tell you now, I'm not. I am not okay with that. The challenge that we as patients face is that we have a wonderful scientific community. It's okay, I eyeballed you two going out. I'll catch you a coffee. No. And not to shame other people because people have places to go, but just to say, please just give the 15 minutes. Patients, when it comes to stigma, are not getting everything they deserve because, as I go back to the weight loss situation, we have a whole market from the media, which is weight loss, weight loss, weight loss, weight loss, weight loss. We have a surgical community, which is unfortunately attached to that weight loss, weight loss, weight loss. It is not attached to obesity is a chronic, recurring, progressive disease. We have a fantastic scientific community who are pushing out papers like there is no tomorrow on obesity as a chronic disease. How much of our surgical community is involved in that? And this morning somebody said, well, you know, we're getting there. We're not really getting there. I've gone from hall to hall and they're full. It comes to obesity stigma and a patient talk, and it's not full. So we're not really getting there. We don't have unity within our communities. So we don't have the full buy-in from the surgical community. And actually many of the people that may be in the room, because essentially we all have implicit bias. Every single person does, me included. When it comes to being a healthcare professional, that is so unbelievably important. I cannot express how important it is that you understand your own bias against patients. When you are a dietitian and they come and they tell you what they had during the week and what they went through, and they kind of feel they fell off the cliff just one evening, do you blame them and go, oh, there we go, there's a sign? It might be binge eating. It might be food noise. Food noise is very, very real. I woke up this morning at about 3 o'clock in the morning. I went to the bathroom. I checked my email because I'm behind on things because ECO's next week, and I wanted to make sure I didn't have any massive deadline from a crazy Turkish printer who is about to lose his plot. And I sat down for 10 minutes on my email. And my first thought was, oh my gosh, I'm so hungry. Now, I checked my blood sugars. I was fine. So it wasn't that. But in my mind, I knew everything that was in that mini fridge because I stocked it yesterday. And I made sure there was fruit and berries. I made sure I had a banana. I made sure I had some seeds and oats and granola. But in my mind, I was like, I want. And what I wanted wasn't in the fridge. What I wanted was a piece of chocolate. But I made sure I didn't have any chocolate. I went to bed and I lay there, and for about 20 minutes I was like, I would love a piece of chocolate. That food noise doesn't go away. I woke up this morning then, and that was still there. My first thought, is there chocolate? And you know your own brain, it goes searching. It's like as if you lose your keys. It goes searching for the keys in the house. Well, my brain went searching for where I could get chocolate. And where I got chocolate was when I actually went down at breakfast with Violetta, and they had little things of Nutella. That's where I got the chocolate. What I'm trying to explain and express to you is that we as patients and we as communities have challenges everywhere. And unless we're all united in what we're saying, what we're speaking to, as in obesity as a chronic, progressive, recurring disease, well, then we're not going to get away from the weight loss. We're not going to change the world of weight bias and stigma. We're not going to stop blaming and shaming people. And as somebody who has lived through that experience and did not attend my very first appointment with my doctor because I blamed myself so much for what I'd done to my body when I didn't even realize that the MC4 or 77 such and such gene actually played a big role in my life and in my family side, because obesity is genetic in our family. And so I went until 30 years old, until I got to 180, 190 kilos. I barely scraped it at 190 kilos before I actually accepted medical intervention. That is not what you want for your patients, because by then, the psychological aspect was so much worse. I'd had 2 children. It was so much worse when you get gestational diabetes and preeclampsia and everything else that comes with it. And as a 49-year-old woman who has various other now, unfortunately, cardiorenal metabolic diseases attached to my obesity and various other NCDs, I can tell you waiting was not the thing that I should have done. But I don't blame myself for that predominantly. I blame the world that we live in and the fact that we didn't do enough. So my ask for you is to please listen to the patients, involve your patients. Don't think that weight bias and stigma is done with because it's been addressed at a talk. No, it's not. It is very real, and it lives in your home, it lives in your clinic, it lives in policies. It is everywhere we look. So thank you very much.
Thank you, Vicky, for the very inspiring communication and experience, for sharing your individual and personal experiences. We have one question, and I would love to share some thoughts that I was thinking while we were discussing. So we don't have much time till the end of it, but perhaps we have time for one question, and yeah, that's it.
Thank you. Thank you very much, Vicky. I want to tell you about a patient of mine that have gone through bariatric surgery. She was obese, and she was struggling in her life because of life events, and was very obese. And after the surgery, she's now on GLP-1 drugs, and now she's underweight. And she's again struggling with her life. And she told me that when she was obese, nobody wanted to help her. And she came to the doctors alone, and she suffered from stigma. And now that she's underweight, she says all the judgment and blame was replaced by empathy. And now everyone's worried, and everyone wants to help her. So it stays with me, this sentence, because I saw how it's see-through. This emotional struggle when people are obese is really see-through. And when you're underweight, everyone worries about you, and sometimes it's the same place. And what I wanted to ask you as a quick question, I'm a registered dietitian. I see my patients in the private clinic for 45 minutes, once a week, twice a month. And you have tens, if not hundreds, of food-related decisions a day. And my question to you is, how do you think we can help you when we're not with you? How can we be there for you? Because when you stood up and you said you have a sweet because your glucose is running low, you demonstrated the difference between talking about it to living it.
To be honest, and this was a question that was asked as well this morning, you know, how can you support? I think if we just step back from the finer details, one of the biggest challenges and problems is that we don't have a lot of, and I know we don't have many surgeons here, but we don't have many of the surgical community involved in the united work going on around the globe. And that is a problem, because we have people who think it is a quick fix. Apparently my Roux-en-Y bariatric surgery in 2005, when I lost half my body weight in a year, was a quick fix. I got the golden ticket according to everybody in my family, everybody that I knew as patient number 50 in Ireland, and I was the youngest patient that had had bariatric surgery in Ireland. When I lost half my body weight, it was amazing, because the amount of people that are like, okay, you should stop now losing the weight. And I was like, yeah, just, you know, you tell my own biology that, right? And that will have a conversation. You know, my hypothalamus is like, yeah, well, let's just go there. Like, essentially, that is very, very real. I have had a revision of my surgery. And when I went into my first surgeon for the revision, he said, Vicky, he said, you know what, you've had bariatric surgery. It clearly didn't work and you didn't put in the work. And I remember going, here I go again. So I've regained weight, it's all my fault again. This was 2021, post-COVID. And then I went to a different surgeon, a private surgeon, and paid an absolute fortune. And he said, Vicky, he said, why wouldn't we revisit your surgery? He said, it's no different to getting a new hip. It's been 15 years. We wouldn't leave somebody with a new hip for 15 years and not revisit and say, hey, okay, surgical intervention has evolved. Let's have a conversation. And that was the first surgeon I met who actually got it. And he says, it is a disease. Let's see if there is obesity in your family and genetics. Ta-da! Yes, there is. And he was the first one that inspired me to talk to the surgical community. And just before we close, the one thing I wanted to share is the most simple thing. And just to say that essentially, this book here, Mom, What is Obesity?, is in 10 languages across Europe, right? And it was created for children to understand obesity as a chronic disease. It is the most simple book. You can read this in 2 minutes. Why on earth are children across Europe in schools in this program learning about obesity stigma, weight regain, and what it is like as a chronic disease, and our surgical community, and many clinicians aren't? That is a challenge that needs to be addressed, and that's where we need the unity.
We have like 15 seconds, if you can, Violeta.
Yeah.
But because the discussion is very relevant today.
Only the 15 seconds is enough. Just, Vicky, I thank you so much for being here and doing this. So I just want to share with you, Alba, Lucia, and I run support groups like 25 years ago. Well, me 25, they obviously less. But I want to share that this is a thing that it has to be widespread also between people living with obesity, because what happened to us, we run different types of support groups. When they come to the one after metabolic and bariatric surgery, that are for people long-term after the procedure, when they come in, if it is late, they say, oh, wait a minute, is this the group of after bariatric surgery? Because I am wrong here, right? So they are impressed because perhaps some of them are already, dealing with their biology, and they experience some recurrent weight gain. So then we are like trying to, right? My colleagues can also support that. So this is a thing that we all have to work on. And we need to do it. We don't need anyone to tell us how to do it. We have to, design the best approach in our area, locally, because we have different realities. So you do in your place, I do in my place, and let's be creative. But also for people living with obesity, between them, that's very important to address. And we do have the possibility, and we are grateful for that, in the support groups that we run. Thank you. Just wanted to share that.
Thank you, Violeta. And we also we want to extend our thanks to Dr. Kathleen Copesco, Dr. Lisa Tuvalten, Dr. Ximena Salas, Mary O'Kane, and Vicky Mooney for their participation in this symposium and for sharing their experiences and knowledge. Thank you so much, everyone.
Victor, yeah.